So, hello everyone, my name's Greg, I'm one of the doctors working in Milton Keynes. So it's a real pleasure to come here and speak to you all today. This talk was actually inspired by events about 7 or 8 years ago when I applied. Let's click the right button on the presentation. When I applied to become a doctor. And all those 8 years ago, you have to write a personal statement to medical school when you want to say, I want to be a doctor. And I wrote that. Now, I'm just wondering, for those who are medics in the audience, does any of this ring a bell? A sort of like, I really like science and I want to help people sort of thing, yeah? Sounds familiar, good, I wasn't alone. So it's a bit like toe-curling naive in retrospect, almost as embarrassing, I guess, as that photograph you see right there. But that sort of incentive never really changed when I was going through medical school. And so I became increasingly more and more interested in actually how much good do doctors do? How much good could I expect to do in the next 40 or so years of my working life? How much better will the world be for my medical labours, or not, as the case may be? So this talk is going to be mainly about that question, and some underlying themes later I'm going to cover in a sec. So we'll talk be in 3 main parts. First, I'm going to do a quick bit of introduction for those who aren't up to speed on like epidemiology or public health, in how we sort of count health and disease, and also the sort of impact medicine is thought to have as per the general consensus of the field. Then we're going to talk a little bit about my attempts to try and have a more robust estimate as to how much good does a doctor do, which I'm going to take as like, what difference does it make if I stay a doctor or if I leave it? What difference could you expect to do during the course of the next 40 years of your life? Or thereabouts. And then, because to give you a spoiler from the title, we're going to find out actually it's quite modest how much good doctors do, how you might think of doing even more good. I'll be focusing particularly on giving to charity. I'll be covering other issues in due course as well. So, with all that said, we should probably get started. So there are 3 main themes I want to cover as a preamble. The first one is this. To what extent is medicine, qua medicine, responsible for a great increase in health and well-being we've seen over the course of the last century? Child mortality has gone down by a factor of 2. UK life expectancy went up in the course of 1901 to 2001, from 41 to around 81. So to what extent can doctors like me take credit for this great improvement in health, both here and worldwide? And the general answer to that, I hope I'm not slandering the field too much, is not actually a great deal. This is a graph from a paper actually published in the 1970s by Macaulay, which looks at US data of like total mortality, so total deaths, on the solid lines, and the dashed line is the percentage of GDP they spent on medical care during that period. And as you see, mortality is sort of plunging before we really get any significant spending on health. And as we accelerate more and more spending on health, the actual downward trend, if anything, slows down rather than speeds up. So on face, there's no great evidence here of like medicine having this like overwhelming role in improving people's health. And they also looked at particular sorts of diseases. Question at the end, I'm afraid, if that's all right. I'm one of the epidemiologists in the audience, so I fear and trepidation. If you look more carefully at these things, they sort of compare death rates from certain diseases, and then the arrows mark sort of allegedly major medical breakthroughs in their treatment, like particular drugs or particular vaccines. And you see, with the exception perhaps of polio right in the bottom right of that graph, there's no dramatic decrease. Often the medical breakthrough has come when most of the deaths have already been averted. So there's obviously a lot more one could say about the sort of relative impact of medicine versus other things. But I think I'm not slandering the field too much when I say most practicing public health doctors think the social determinants of health, such as wealth, education, sanitation, and other things besides, have most of the role to play when it comes to improving health and disease, with medicine relegated to a fairly ancillary role. The next thing I want to cover a little bit is how we measure health and disease. So I talked about deaths previously, but there are other things disease can do to one besides kill you. It can make you blind, it can make you suffer. So, and also there's obviously the fact that everyone dies eventually. So even if, for example, Richard sort of had his son clutched his chest and falls to the ground, and I, being the doctor I am, leap to his aid and revive him, just like they do on all the medical dramas, it's not the case he becomes immortal. He'll unfortunately, sorry Richard, die at some stage in the future. Well, that's only talking about sort of length of life. We may also want to care about quality. Because, for example, if Richard suddenly went blind, and I, again, by the magic powers bestowed on me by my medical degree, cured him of blindness, he may not live any longer than he did previously. But I think most of us would be agreeing that his life probably has been better for having avoided becoming blind. And so what epidemiologists and public health doctors tend to do is they talk about quality-adjusted life years, or health-adjusted life years. And so instead of looking at length of time, you also have a y-axis, which measures health. This is extremely controversial, because obviously then you have to sort of measure how bad certain disabilities are relative to one another, and relative to being at full health. One example is that being blind is weighed at what's called at half weighting. So it's thought that 2 years of blindness are worth the same in public health terms as 1 year of healthy life, which is deeply controversial. I'm not going to try and offer a defence of this metric here and now, but I will say I think most people agree you should be trying to look at both length and quality of life. And although DALYs or QALYs or health-adjusted life years are by no means perfect measures, they're the best ones we've got. And they're used both nationally by the National Institute of Clinical Excellence and globally by the WHO and the World Bank, amongst others. So, with all that said, perhaps we can move on to looking at how much good doctors do. What difference do I make in my medical career? So, I was hoping, actually, when starting to do research on this, there'll be a big literature looking at the sort of impact of how much good doctors do. And you'd think medical profession being so interested in doing good, it would want to look a little bit introspectively at finding out how much good do we do. And also, if you're trying to construct a health system, working out the relative benefits of having doctors employed would be quite an important thing to do. And so I looked at the literature, and I couldn't really find a huge amount. The only real person I could find who looked at this, I welcome any suggestions of others, was a guy called John Bunker, who was an anaesthetist and now a public health doctor. And he tried to sort of work out how much good does medicine as a whole do for people living in the United States. And his technique was the following. He sort of totted up the most common 200 or 300 medical interventions, things like tablets to high blood pressure, opening out arteries in case of heart attacks, things like that. And he took the top few hundred, and for each of those he looked at the primary research literature to work out what sort of survival benefit in both length and quality of life do these things have. He then totted all of these things up to work out the total good done by medicine, or so he alleged. And it's sort of headline figures of these. Thanks to medicine, it's thought, we can live all 5 years longer than we would had we not had any medical care. We also have 5 years free of disabilities, again, on average, thanks to our doctors. On the downside, though, each of us lose half a year of life thanks to doctors making mistakes. So we're net positive, at least, right? So we can then use this with our sort of health-adjusted life year metric to try and work out how much good does medicine in total do, and then divide that up by how many doctors there are, and so work out the impact of our medical career. So this is how we do it. So if we say 5 years of extra life is 5 years of healthy life, 5 years free disability is 2.5 when we assume, for sake of argument, all disabilities are really, really bad as blindness is thought to be. But then we obviously subtract 0.5 for the sort of math errors. If you total that up, you get 7. So it is on this sort of estimate, everyone in the UK lives on average 7 years longer thanks to the work of doctors like me. And then for work of the moment, to multiply that by the UK population, which is about 62.6 million people, to get a very large number, divide it by the number of doctors, which is about 172,000, and you get this thing. So on this sort of back of the envelope estimate, you get each doctor like me adds just over 2 millennia of years of healthy life, thanks to our medical career. And that's pretty good. If you think of saving a life as like adding 30 or so years of someone's life, you can say you save 2 or so lives every year you work, which is pretty good, right? But as I'm going to go on to see, that's going to be a very large overestimate of the true impact of medicine, for a variety of reasons. The first one is, we know from bitter experience that clinical trial data over-predicts real-world performance in terms of improving lifespan, improving quality of life. The reasons of which varies, partly publication bias, partly you preset your patients very carefully, and things like that. Secondly, though, obviously, as I mentioned earlier, most disabilities we're making you free from, according to Bunker, will not be as bad as blindness. Most disabilities aren't. So those 5 years of free from disability don't really count as 2.5 years of healthy life. Perhaps one of the more important things is a thing called diminishing marginal returns. And this is the idea that if the first doctor in a population has a much bigger impact from, let's say, the second, the third, the fourth, and the fifth. Because the first doctor can do the very most important things in that population, or assuming they prioritise appropriately. Whereas, and then in turn, they leave less and less sort of worthy things to do for people later down the line. So, for example, I went to a talk by the only orthopaedic surgeon in Malawi for several years, and he spent, besides building a hospital, he spent all his time fixing broken limbs and transforming people's lives. But if he was an orthopaedic surgeon working in the UK, all of that would already been done by his colleagues already, leaving comparatively, relatively speaking, minor concerns for him to do instead. So if you imagine this graph, technical diagram, where the upward graph is amount of health or smiley faces, one would think the first doctor has like a very strong impact with a steeper curve. But as you get more and more doctors, the opportunities they have to improve health get less of lower and lower magnitude. So diminishing marginal returns. So here's where I come. So instead of doing what Bunker did, which is like where you try and sort of produce an inventory of all the different things you do, and then sort of top them up to see how much good like I do when I dispense out some drugs, and so on and so forth. We can instead look at sort of overall global estimates of health and disease, and try and tease apart relationships in those data, and then sort of try and work out what sort of influence medicine has on total measures of health and disease, or so I hope. So if you're looking at very big data sets, WHO's got one of the biggest of all. So for each of 180 countries in WHO, they report estimates of DALYs per 100,000 people, a number of doctors. So DALYs, unfortunately, are not quite the same as QALYs, but at a first approximation, they are inverse QALYs. So whilst you gain years of healthy life for living longer and being healthy, you gain disability years for dying soon or being sick. There's more to it, but I think that'll suffice for now. And so you see actually from this graph, this very sudden falling off as you start, but then it levels off quite dramatically as you add more and more doctors, sort of, one might argue, proof positive of diminishing marginal returns hypothesis of how medics translate into health. And you see this elsewhere as well. So if you look at, for example, total wealth, so GDP per capita versus life expectancy, you see a similar sort of leveling off with like more and more money giving you progressively lesser and lesser gains in health. And if you look at health spending in particular, you see a very similar sort of relationship. So, with all that said, one perhaps quick way of trying to work out the sort of marginal impact as a doctor, how much difference would I have made being the like 1,702nd doctor or something rather than the first doctor, is to try and produce a best fit line for these set of points, and then see what happens when we move along that line. So, with an example of like blood, sweat and tears on a statistics program, I managed to produce what's called a hyperbolic curve which fits this data. And that's actually, it's a fairly good fit. The R squared is around 0.8 for those who care. The p-value is well under 0.01. And so what we can do from that is we can look at, for example, where the UK is now in terms of doctors per 100,000 people. And then we can work out, if we add one more doctor, you or I, to that number, how much further along do we get? I've exaggerated, obviously, in the sake of this diagram. So hopefully, as we go add more doctors, the amount of disability years goes down by a very small amount. And from there, we can try and estimate the sort of impact I have as a medical doctor. And so let's look at the numbers. So the UK has around 274.3 doctors in 100,000. With one more, it has a fractionally larger number, obviously well within the margin of error, 1/10,000th of a doctor, in fact. Obviously, this is obviously an abstraction, not like dividing each medical graduate up into like 10,000 different pieces and mailing it to each hospital. But I think it's fair to say it like makes a good measure of like expected impact. There'll be one more doctor in a certain place, but one fewer doctor everywhere else. So it should, one would hope, average out when you have data sets as large as this, on which more later. And then if you move along this best fit line, you get a decrease of like disability years of just under 0.025 per 100,000 people per year you work by adding one doctor. And then you multiply this up, saying, so one doctor like me, each year they work over 15 disability years, so adds 15 years of life to a first approximation. So multiply it up, you get 600 health years per health career. So 3 times lower than our previous estimate, which was looking pretty good. But that's still looking all right, actually, because that's like saving your life every 2 years. So in the course of my first 2 years in the foundation program, I will save a life, which is pretty cool. However, and there is a big but, this figure is also going to overestimate. The main reason for this is, of course, as I just mentioned a little while ago, we know other things besides doctors have an influence on this. And we aren't correcting for any of the possible confounders which might both correlate to both number of doctors and amount of health and disease, like, for example, wealth, education, things like that. So, as we know these things are we think these things are the bigger factors, we should really try and take into account those when trying to model health and disease, and then working out the impact I have as a doctor. So, part 3. So to try and take account of this, I've done a mathematical thing called multiple regression. We have what we're trying to predict, which is population health, however we want to call it. And we have a list of potential candidates what might be explaining why some countries are healthier than others. Doctors are amongst them, but so is wealth, so is sanitation, so is inequality, and so on and so forth. And to spare out a lot of mathematics, the trick you try and do is use your stats program, or a lot of maths, to try and figure out which of these factors, or how strongly these factors each influence the outcome variable we're looking at, which is population health. So you get something like this. So you have a lot of constants multiplied by the variables, and so on and so forth. There's a little bit more to it to make the data fit, which I'm not going to mention, but I was mentioning to the epidemiologists, don't kill me. So, if we can work out two things with this. Firstly, we can begin to look at which factors are the major players, which factors predict best health and disease. Are doctors the main thing, or is it perhaps something else instead? And then try and work out how big a difference do I make when I become a doctor. We can then use our model and use it in reverse. So we know what the UK's how rich it was, how healthy it was, and things like that. And so we can use the model to predict how healthy it was, as it were, back then. And also, if we tweak the doctor dial by that tiny amount representing one more doctor, how much more health do we gain by doing so? So, and again, just running the numbers. So if you run our model like we constructed, we get a virtual figure of days, which is around 13,000 people, 13,000 years of unhealthy life, 100,000 people, which is actually within about 10 or so % of its real value, as measured at the time, which isn't bad. If we twiggle the dial just a little bit, we get a very slightly small number. And then if we multiply it by the UK population, by the same sort of trick, each year I work, I avert, it said, 4 years of healthy life per doctor. And again, multiplying by our 40-year career, we get something like 160 years of healthy life added, or 160 years of disability averted, which is about the same, you might argue, as saving a life every day. So we've gone a long way down from saving a life 2 lives every year, saving 1 life every 10 years. Down by a factor of, I think, 10 and a bit. And I think the news unfortunately gets a little bit worse than that, because actually that is also probably going to overestimate for a couple of reasons. Because we've been assuming so far the difference is me or a Greg-shaped hole in the medical profession, where there are no other doctors who are going to fill my place. But of course, were I not to apply to medical school, there would be likely someone else who would have. Someone probably similarly as good as I was. So the difference I make is not so much a difference between me or no one, but between me and some fairly good person who just missed out on medical school, which is not going to be as big. Also, doctors, I don't work for free, unfortunately. Your taxes pay my salary, as I'm often reminded. And so the sort of costs we impose could be spent elsewhere. There's an opportunity cost as well. So I hope we're actually a pretty good deal on that. But all the same, there's still further things to be accounted into before working out the net benefit I make as a doctor. So that's where we are. That's the research as it stands so far. Advice on how to improve it is very welcome. So, the story so far. The impact we make as a doctor will, on average, be fairly modest. Unlike, when you watch ER and they save 7 lives every week by jumping onto defibrillator pads, it's rather the case that each of us makes the world slightly better by being a doctor, but not by a dramatic amount. And obviously the pessimism comes from that as I use better and better statistical techniques, the estimate keeps getting lower and lower. Hopefully it won't cross 0, because I'll be but I wouldn't be surprised if it drops again by maybe another factor of 2, if you try and start doing things like measuring elasticities of supply and demand and other sort of technical tricks like that. So, I think the 17-year-old version of me, with his Union Jack flag and Union Jack tie, would have found that pretty depressing stuff. Rather than saving life every day or even every year, I'm perhaps working very hard for 40 years and maybe saving a couple of lives, or more likely and more realistically, adding increments of health and lifespan to people whose lives have probably gone pretty similar otherwise. I might add, let's say, half a quality here and maybe extend someone's life by a couple of months there by prompt treatment. But it's not like the sort of dramatic life-saving stuff I perhaps dreamed of when I applied to medical school. And maybe that's the same for you guys as well. Of course, if you're not a doctor, I guess you find this quite reassuring and you can abuse your colleagues who are medics. So that's the bad half of the bad news. I'm going to go on now and talk a little bit about the good news. Okay, so let's look a little bit more at health and wealth. So this is the graph I showed you earlier of disability on the y-axis versus doctors on the x-axis. And there's more, if you look at, say, the poorest also countries, the fewest doctors, they're also the poorest ones. And you see, for example, things like there are thought to be like 95% of all child deaths under 5 happen in these countries, in the lower economically developed countries. Your risk of dying during childbirth is 100 times higher in certain countries versus certain other countries, say Niger versus Singapore. And there are 26 million or so poverty-related deaths every year. That is to say, deaths which plausibly could be prevented were certain medical things, certain social things more readily available. Food and water, amongst others. The other thing is, when we look at, say, income versus amount of people, we get a very different looking graph. So this is like the percentage of people earning less than a given income, and the income goes up on the y-axis there. It's worth saying this is, when economists try and construct these sort of graphs, they already correct for the fact your money goes further in the developing world. So that factor is already taken into account when we look at these sorts of graphs. So we already have about 40% of the planet living on $2 a day, maybe slightly less now, since I looked at the data, which is pretty bad. In comparison, the median person in the UK, the median UK income, puts you already in the top 3 or so % of the global population. And in fact, just to put in perspective, the bottom 1% of those living in the United States still earn more than the bottom 60% of those living in India. Now, if you graduate from Imperial, which I'm sure most of you will, the average income of a first-year Imperial grad puts you even higher still, in the top 2 or so % of the world population by wealth. If you become a doctor like me, you'd expect your average income over your lifetime to actually be off the chart, putting me, although I'm not there yet, as my income grows at will, in the top 0.1 to 0.001 of world population. So you might then think, as I did actually think, well, maybe given I've got so much and others have so little, can we do good by giving some amount of amount I have? Well, given I have so much and others have so little, could we do some good by giving some amount of my relatively large amount of money to those who have relatively little? And so you come to like discussing how much good could this do, and how much good could this do compared to, let's say, the next 40 years of my life working as a doctor. So I'm going to talk a little bit about effective charity. I want to try and impress 2 main messages upon you. The first one is we don't really care about efficiency, as in how big the overheads are, how transparent you are, things like that. What we really care about is sort of a means to the end. It's like efficacy. What actually happens when I give money to this charity? To try and persuade you why you should believe this is the case, I present Exhibit A. So this is actually a real charity. It's called Homeopaths Without Borders. So, and they work actually, I think they recently started working in Malawi. I think they've also started working in Haiti as well. So you can fund them to both sending homeopaths over there to work, and also for them to train other people to be homeopaths, so it's sustainable, right? And I think, with respect to those who believe in homeopathy, medical science generally is not a big fan of it. In fact, we think it's basically got no benefit beyond placebo. It might be, in fact, harmful. So it doesn't really matter how efficient they are, how little they spend on advertising, how little overhead they've got. None of that really matters, because what they're actually doing with the money is not going to make a difference. And we should really care about what the difference we make. But then you might say, okay, fair enough, so try and avoid like charities like that. But surely, if we like sort of devote ourselves to like a charity working on somewhere suitably poor and desperate, and that's what they're really doing, surely they're all doing good work. So as long as I sort of, I don't know, give my money to UNICEF or MSF or somewhere, that's money really well spent. I don't need to think any more than that about what's going on. And that's not quite the case either, because it seems, at least according to the data of the World Bank, WHO, the actual intervention you spend your money on, or charities spend your money on, vary by very large amounts. So I'm going to talk a little bit about interventions in treating those with HIV or AIDS. This small arrow is the sort of size of benefit you get by treating Kaposi sarcoma, a skin cancer commonly associated with AIDS. This obviously does some good, but it unfortunately doesn't do very much, because it tends to be something that affects the end of someone's life, and tends not to be their biggest health issue. So you're improving generally the end of someone's life with AIDS by some small amount. Worthwhile, absolutely. But even if we were trying to be the NHS and spend money on treating diseases, the actual efficiency of that is, or efficacy, sorry, is 0.6 healthies for every £20,000 you spend, which is below NICE's unofficial threshold of £20,000 to £30,000 per every healthy you buy. So can we do better? And we can. So this slightly longer yellow arrow, which unfortunately is projected very well, is the impact you get by spending your money instead on antiretroviral treatments. This is actually what the US did for a very long time in sub-Saharan Africa under the aegis of George Bush, spending up to 60 or 70% of the international development budget on funding clinics in sub-Saharan Africa to dispense antiretroviral drugs to those with HIV. These drugs have the benefit that they hopefully at least put the HIV into a quiescent state effectively for at least some length of time. So you're hoping you can improve their lives and lengthening it, which is great. But maybe you can do even better. So the slightly larger green area is what you do when you target your drugs towards stopping vertical transmission. What this means is HIV is not only spread through sex or through sharing needles, but also from mother to child via themselves. So if you target your drugs towards protecting pregnant women who are about to give birth, you hopefully limit the chances of their children being born with HIV. So prevention, hopefully, rather than amelioration. But could you do even better than that? And yeah, you could. If you instead try and stop horizontal rather than vertical transition by, for example, condom initiatives, we think you do about twice as much good again. So 200 health years per £20,000. Could you do better than that still? Well, the answer is yes. If you try and educate people, particularly those in high-risk groups, like prostitutes or those who use intravenous drugs and things like that, and tell them what HIV is, what you can do to limit your risk, you have an even bigger health impact. So we've seen by just traversing one disease, we've gone over just under 3 orders of magnitude, which means basically, if I spent the contents of my wallet, which is not a huge amount, on the green arrow, I'll be doing about as much good, or maybe more good, than giving my year's salary to treating Kaposi sarcoma. So it really matters where you put your money. And then finally, you might think, well, is there something even better than treating HIV? There are many diseases in the world, after all. Is there an even better buy in terms of global health than treating HIV? And it seems there is. So if you, for example, spend your money on insecticide treating malaria nets and give them to people who need them, it's thought you add somewhere in the region of 1,000 years of healthy life per £20,000. So 1 year of healthy life per £20 you spend. So in reflection, each year I work as a doctor in the UK, you can do about as much good by spending 80 quid to a charity which gives malaria nets away. Whoops. So to work this out, so if I, as a doctor, start giving my charity, I could hope to do quite a lot of good. So suppose I work 40 years and give 10% of my money throughout that time. I earn, on average, I earn less now, hopefully earn more later, if I strike me off beforehand. Times that by the amount of years, and say you give 10%. This gives you a figure around the region of £280,000. And given our sort of best charity we think gives healthy years at around 20 quid a pop, divide that through, and you get this number. 14,000. Which is about 100 times better than I thought I could do by being a doctor myself, by giving a relatively small amount of money to charity. Instead of being off the chart, I'll be on the chart, but only just in terms of global health and wealth. So that's saving a life every month. So,
Okay.
people, one thing I should note in this slide, you may think I don't believe those numbers. Well, those numbers are actually more conservative for numbers WHO themselves use when they're trying to work this out. If you believe the WHO figures, you can save lives for about save add years of healthy life for 3 or 4 quid each. So we're being conservative when I gave you those figures, not optimistic. Anyway, so given all this, and you want to make the world a better place, you are, like me with your Union Jack and bow tie, or words to that effect, trying to make the world get better. What should you be doing with your time? So the bad news for medics is obviously this. But the amount of good you can do over your career, even if you're a really, really good doctor, is likely going to be swamped by most other things you can do instead. The impact you make as a doctor is fairly modest. Worthwhile? Absolutely, I really enjoy it. But if you want to make the world a better place, why are you not doing it? Medicine is not the place to go, it seems, on the face of it. The good news for everyone else, including doctors like me, is if you give your money wisely and with care, you can do much, much more good than seemingly sort of terribly moral careers like a career in doctoring could be. So all of you, I anticipate, could comfortably eat my stethoscope with your checkbook, if you knew how to use it. And now you do. So the next things, I guess, sort of looking further for those who are interested, is like, how could one put this knowledge into practice? Because the underlying theme of this talk is not just about how much good doctors do, but actually how tricky and how opaque the world often is in terms of changing it. Because I think most people would have thought that medicine is like a fairly commonsensically good career, even with people like me. And finding out that in fact you could do much more good than I could do by fairly modest things, like giving some money to charity, I think is quite surprising. And Rogers is that sort of way. And so given all this, what could one do instead? So one might think about sort of different sorts of causes. So I use fair trade as an example. One may argue that like the main things one should be doing with one's time, rather than sort of like trying to sort of like treat the underlying cause, of the problems with global health and disease. So fair trade is one of many, many others which are attempting to identify structural issues in the world and trying to make them better. So maybe you should be devoting your time to doing this instead. Maybe you should be working in politics. Of course, it's very tricky to work out, for example, which particular thing you should be doing, which particular structural intervention actually works. Fair trade is very controversial, as is free trade, as immigration, as many other things you could propose as ways of making the world go very much better. But it seems worth exploring to try and find out which ones really do promise to work out. The other thing is this. Although the world has generally gotten better in terms of health, we've all got richer, we all tend to live longer, we all tend to die less. In some respects, the world's getting a lot worse. And those respects are basically only related to the climate. So global temperature, CO2, things like that. And it seems, according to the Lancet and many others, that climate change will become a very large threat to stopping the world going where it's currently, pleasantly going upward trajectory. And so perhaps we should be looking outside of clinical practice altogether in terms of making the world really become a better place. Maybe medicine really can't do that much good. We may want to actually start thinking outside of medicine. I propose these sort of ideas just really to stimulate interest and start discussion. If you want to sort of make the world a better place, maybe you care about not just human suffering, but suffering of animals, such as like orangutans, cows, sheep, things like that. So it's thought that somewhere in the region of, I think it's around 2 billion animals a year are slaughtered for food each year. And so if you think that these have interests or welfare and it's worth preserving them, you might think that as vast as the suffering of humans is, maybe the suffering of animals is even more important for the sake of argument. And if so, maybe we're treating the wrong species, let alone doing the right things for them. Finally, I mentioned climate change. Yes, there we go. I'll be back. No. Climate change is one of many things that people worry about and make the future go worse. But it's not the only thing that people worry about. So there's like a small diaspora of academics in Oxford and Cambridge who really worry about basically when the computers get really clever and destroy the world, or when we release an engineered virus onto the world, or things like that. You may find some of them absurd, but I think it would be unwise to discount all of them as being ridiculous. We know for a fact, thanks to climate change, humans can make the world go much worse for each other. And as our technology improves more and more, our potential for negative impacts grow higher and higher. So, enough about causes. What could you do instead? One question I often get is, well, if giving money beats being a doctor so good, why are you still here? Why are you not like joining the city or becoming a banker or doing something like that will earn a lot of money and thereby giving more of it away, and so doing much more good than you could ever hope to do being a doctor? And the answer to that question is like, well, maybe I should be doing that. If I knew then what I know now, I don't think I would become a medical student. But I know now. So maybe, as some people I know do, we should literally try and seek out very high earning careers just so we can give them money away. Is one potential option trying to make the world go much better. But maybe there's other things we could do instead. So if I persuade you guys to, let's say, give 10% of your money to charity, then if I persuade like a couple of you to do that, I've done more good than I myself will do with my own salary. So by trying to promote these ideas and sort of maybe persuade people to do it, I'm not sure how effective I do either of these things, maybe that's a worthwhile thing to do as well. We might also think that trying to research how the world goes might be important as well. Research not only on particular diseases like malaria or HIV or anything else, but also like research like this on like what actually happened when I become a doctor. What makes the world better? How should I plan my career to make the world go better? What could I be doing instead? And that's like seems to be very underlooked at and deserves to be looked at much more. Or maybe something else I haven't thought of. Suggestions very well. So, things you can do. This talk has sort of grown out of an underlying movement which is called effective altruism. The idea is really just trying to think strategically about how to make the world go better. Hence we see why, in a world where, for example, 40 years of my life working as a doctor does less good than a couple of £1,000 given to right charity, it's even important to think carefully about these sorts of things. If you find that sort of thing interesting, here's what you can do. There's a group called Giving What We Can, which helpfully sponsored this talk. I'm a member as well. The idea is you give 10% of your earnings to what you think are the most effective charities to make the world go better. I wouldn't recommend it. I give more than 10%. I don't miss it at all. I still fund my booze habit adequately. My life goes very well. I'm still well above average in the UK population and still in the top percent of the world's population. And I'm very happy doing so. So if you want to do that, please do. There's another group called 80,000 hours. 80,000 hours is the amount of hours you spend working in the course of your career. So it seems very important to spend that time wisely. So spending that being a doctor only as a doctor may not be the best idea if you could do more good elsewhere. And so thinking carefully about sort of how should I spend my life if I want to make the world go better is really important. And also not looked at very much. So I remember I'm quite heavily involved in it. I'm very happy to put you in touch with people if you're interested. Finally, mostly for those who are medics, I'm slowly trying to set up a network of medics who are interested in thinking about these sorts of things in this sort of way. So if you find that interesting at all, I'll be very grateful if you get in touch with me and we'll try and produce a movement or a community. Anyway, thank you so much for your attention. I hope it's proven interesting and hopefully informative way of spending about 40 minutes of your time. I'm very happy to answer any questions. Thanks so much.